Okay, let's get you. Yeah.
Just you want me to turn it on before I start talking?
Exactly. When you want a smoking gun situation going on, pertinent information. And so you don't look like C3PO when you put these wires up. Or RTD2, 1 and 2. Turn it on, let's test it out real quick.
Testing. Yeah.
Good. So whenever you're ready,
Okay.
slide answers right here. Red pointers right here.
Does it work on that screen?
Yes. You're good.
And is there a mouse?
Yeah.
I wanted to point with the mouse. I could do that too.
Yes.
Okay. Good.
Yep. And water and
Good.
wonderful. Thank you.
Welcome, everyone. It's my pleasure to be able to welcome the introducer to this combined pulmonary critical care and ethics noon lecture. This is, I think, the second that we have combined on, and I think this is a tradition that is turning out to be quite worthwhile because critical care has a whole lot of ethical issues involved in it. Today, Dr. Tan Nguyen, one of our critical care specialists and a clinician investigator who thinks a lot about decision making in the ICU, is going to introduce our speaker. The connection between the two is that her main paper thus far in JAMA Internal Medicine had an editorial by Dr. White, and I think he might shed a little bit of light on the kinds of things that we think about in his talk today. So with that, let me introduce Dr. Tan Nguyen.
So it is my great pleasure to introduce Dr. Doug White for our joint ethics and pulmonary grand rounds today. So when I became interested in health services research and critical care, I constantly came across Dr. Doug White's name in the literature on ICU ethical issues, on decision making, and I knew that he was a highly influential and accomplished individual. I didn't meet him until recently and was shocked to realize he was not an old, white, bearded-haired man that I had imagined given his accomplished status. He's not that many years older than myself, just decades more accomplished. So Dr. White graduated summa cum laude from Dartmouth College in 1995 and received his MD from UCSF in 1999. He also completed residency and pulmonary critical care fellowship at UCSF. He then obtained a master's degree in epidemiology and biostatistics and a fellowship in bioethics and joined the faculty at UCSF in 2005. In 2009, he joined the faculty at the University of Pittsburgh and now directs the University of Pittsburgh Program on Ethics and Decision-Making in Critical Care. He has an endowed chair for ethics in critical care medicine. He has several ongoing NIH-funded studies and has published widely. His work focuses on ethical issues that arise in intensive care units, including the allocation of scarce resources and resolving fertility disputes. He also chairs the ATS task force on developing a consensus statement on inappropriate treatment in the ICU. Today, he will be discussing why is there a disconnect about prognosis between physicians and surrogates in the ICU. Please join me in warmly welcoming Dr. Doug White.
Thank you, Tom. Wonderful. First of all, thanks so much for having me, and it's great to be here as part of a combined ethics pulmonary critical care session because, as Neil said, there is I think a lot of the business of ethics consultation does arise in the intensive care unit, and the overlap is, I think, growing day to day. So today I would like to talk about one fairly discrete issue that comes up in intensive care units, which is the well-known discrepancy between clinicians' expectations about prognosis and the expectations of surrogate decision makers. I have no relevant conflicts of interest to disclose. The work that I'm going to be presenting here has largely been funded by the NHLBI and the National Institute on Aging. So the backdrop for this is that if we think that patients, or when they're incapacitated, their surrogates should be involved in treatment decisions, and I think there's a general consensus that they should be involved in some way, then they need to have an adequate understanding of the likely outcomes of treatment if they're going to be truly informed participants in the decision-making process. The problem is that there are about 2 decades of research that suggest that this is really not the case, that quite often surrogates have inaccurate expectations about the likely outcomes of treatment, generally in the direction of overly optimistic estimates. So this is just a list of the various studies in the last 10 to 15 years that have documented inaccurate expectations about prognosis by surrogates, the most recent being a study by Chris Cox and colleagues in critical care medicine. And just a quote from that study, most surrogates reported high baseline expectations for 1-year patient survival, functional status, and quality of life. And when they looked at the concordance between the clinicians' expectations and the surrogates, they found that essentially the degree of agreement was no better than chance. That's what a kappa of less than 0.08 means. That it was just random, essentially. And so this, if we really take to heart the notion that surrogates need to be adequately informed to be involved in treatment decision-making, this is a major problem. In part because we know that prognostic information clearly influences patients and surrogates in their treatment decisions near the end of life. Again, I don't want to spend a lot of time going into these data. It's not the topic of today's talk, but I'll point you to a number of RCTs and observational studies indicating that patients and surrogates both are less inclined to opt for aggressive treatment the worse the prognosis. And Terry Freed's study from the New England Journal, published in 2002, she took a group of about 300 patients and surrogates with advanced illness and gave them a variety of scenarios in which she varied the likelihood of adverse outcomes here on the x-axis, and then on the y-axis, the proportion of people willing to undergo various levels of invasiveness of treatment. And what she found, not surprisingly, is that as the likelihood of an adverse outcome, i.e. death or severe functional impairment, worsened or increased, the proportion of people willing to undergo the treatment declined substantially. The other big question that this should be raising in your mind is, well, can clinicians even prognosticate in ICUs? Is there adequate expertise or data to inform predictions that could be shared with patients or surrogates? And there is a relatively large literature on this question. This has been reasonably well summarized by Taz Sanaf in a meta-analysis of 12 trials in critical care medicine. And essentially what Taz and her colleagues did was summarize studies in which they compared clinicians' prognostications with various types of computerized scoring systems like the Apache scale and looked at the accuracy with something called the ROC curve. And a score of 1 on the ROC curve is perfect accuracy. Anything less than 1 is less than perfect accuracy. 0.5 is no better than chance. 0.92 is the accuracy of troponins to diagnose acute MIs for frame of reference. And what they found is that the area under the summary ROC curve was 0.85 for physicians' predictions with good discrimination between survivors and non-survivors. It's really important to know how they elicited clinicians' prognostic estimates, which was, number one, early in the ICU stay, and number two, they didn't ask, will this patient live or die? They asked, what are the chances this patient will survive to hospital discharge? So using that sort of probabilistic prognostic estimate, clinicians are relatively accurate in their predictions. There are other data that I'm not going to show, but a study by Meadow and colleagues at University of Chicago in particular, that if you ask clinicians, will this patient survive to hospital discharge? Yes, no. So rather than a probabilistic outcome measure, a binary, that clinicians' predictive accuracy is relatively poor in identifying the patient who will not survive to hospital discharge with certainty. And what this leaves us with is this interesting paradox where we can't do a great job of prognosticating for individual patients with certainty, but we're pretty accurate if we use probabilistic expressions of likelihood of survival. And so it raises the question, well, is this useful information for surrogates? Do they care what we say about populations of patients? How would they handle this uncertainty? And so one of the first studies that we did looking at surrogates' perspectives on this was an in-depth study that I've summarized here, and I had no expectation that you'd see this, except the point is to make the point that we interviewed about 180 surrogates and put to them this issue. Many times clinicians are worried about talking about prognosis because they're not certain of their estimates. How would you advise clinicians in that circumstance? And we did these in-depth interviews with people, recorded and coded them using basic grounded theory analysis. And the gist of the finding, the quantitative finding, was that 95% of surrogates said, listen, we want prognostic estimates, even if you're not certain about them. We want to hear your best estimate. And oh, by the way, the prevailing sentiment was, even if the doctors thought that there was not uncertainty, we think the doctors they can't predict with certainty the kind of things they think they can predict with certainty. What I take from this study is that surrogates are more tolerant of uncertainty and want to hear prognostic estimates even when there is that uncertainty. So then this takes us, with this background, let's sort of switch gears to the primary question that I posed in the title. Why the disconnect between clinicians and surrogates about prognosis? And what I'd like to do for the next few slides is take you through a few different potential explanations and then look at the data behind them. And the first potential explanation is a very simple one. It's just that the reason that clinicians and surrogates are not on the same page about prognosis is that clinicians don't talk about it. That would be the claim, is that it's a failure of disclosure. So we set out to answer, and then you don't have to look too far for people thinking this is the case. This is a column in Newsweek, a journalist recounting her experience of really struggling to get clinicians to talk about the future. Some evidence from the medical literature comes from Nick Christakis' work in the oncology field, documenting a fair reluctance on the part of clinicians to disclose prognostic estimates. But no work had been done in intensive care units. So we basically, over the course of 2 years, we had a series of audio-recorded conversations between clinicians and families in ICUs that were audio-recorded and transcribed, 51 conversations that we coded using a qualitative coding framework that I developed to look and see every single time clinicians talked about anything having to do with the future. And the question that came up is, are clinicians talking about the patient's prognosis during these conversations? So the simple answer, when we ask the question, are there any prognostications in the conferences, that in 98% of them, the answer was yes. In the one conversation where there was no discussion of prognosis, it was actually a brain-dead patient. So in truth, prognostication is not relevant in those circumstances if you're taking seriously that brain death is a final condition. And we looked to see the number of different prognostic statements. And what we found is that, in fact, there's quite a lot of conversation about the future. So looking at it in this way, it suggests, well, it's not that they're not talking about prognosis. That's probably not the explanation. I think the picture is a little more complicated because we also went and broke down the kind of conversation about prognosis by the type of statement. And I'm sorry if this is not projecting well. We looked to see, we subcoded for prognostic statements about short-term survival, long-term survival, functional outcomes of various types, freedom from mechanical ventilation, likelihood of ability to care for oneself at home. And what we found is that in more than a third of conferences, there was no conversation about survival, about the patient's likelihood of survival to hospital discharge, and even less about their long-term chances for survival. So in answer to the question of, well, is this an issue of a failure to disclose? I think the answer is less clear than yes or no. And sometimes it might be. This might be a contributor. And other times there may be something else going on. So another simple conceptual model is that clinicians are disclosing the information, but surrogates cannot comprehend it at the literal cognitive level. They simply can't understand it for a variety of reasons. They're anxious, they're overwhelmed, it's too complex. And so we set out to look at this, to answer the question of, are these various papers that claim that the issue is misunderstanding about prognosis by surrogates. This is just a host of various studies looking at the topic, and they're empirical studies documenting discordance about prognosis between clinicians and surrogates. And when you look at the data, I'll explain in a while why I think misunderstanding may not be the right word to explain the findings that these individuals had. Nonetheless, we set out to test this in the intensive care environment by testing two hypotheses. First, we hypothesized that surrogates and ICUs can comprehend physicians' prognostications when those prognostications are embedded in a typical family meeting. And second, this was a more methodologic risk communication question, quantitative prognostic statements will be better understood than qualitative statements. What I mean is a quantitative statement like 10% chance of survival versus a qualitative statement like very unlikely to survive. So we did an RCT, 169 surrogates of people, of actual incapacitated critically ill patients. The individuals were actively engaged in surrogate decision making. And we asked them to come to a separate room adjacent to the ICU and view, they were randomized to view one of two versions of a simulated family meeting, a video done by trained actors. Okay, so that was the intervention. We went to great lengths to say this is not about your loved one, this is a separate thing. We're interested in your perceptions of how the clinicians are communicating. And let me just take you through a bit what the simulated family conference was. We were following existing best practice guidelines in the development of this in terms of the content of the family meeting. It started by the clinician introducing himself. It was actually a one clinician, one surrogate meeting, which is a little atypical. Then explained the medical situation briefly using basically an explanation of organ system dysfunction. It was a patient with ARDS, vent-dependent multi-organ failure from sepsis. The clinician then expressed empathy, elicited information about the patient as a person, disclosed a prognostic estimate. I'll show you in a second how. And the video simulation ended with the clinician and family deliberating about what's best and agreeing on a time-limited trial of therapy. And so the randomization, the two versions of the simulation varied only by how the prognostic information was provided. It was basically a cut and paste. So it was the exact same actors, the exact same statements, except for the prognostic statement. And in the quantitative version, I would say he has about a 10% chance of surviving. Saying in another way, that means there's about a 90% chance that he's going to die. And in the qualitative version, I would say it's very unlikely that he will survive. Saying in another way, that means it's very likely he's going to die. So the conference was about 7 minutes long. It's a little shorter than the average conference. And a question that might come up is, well, how can you make quantitative comparisons when it's not totally clear what it means to clinicians when they say, I would say it's very unlikely that he will survive. So basically, we experimented with a number of different statements, and we gave these statements to physicians at UCSF, where the study was done, and said, if you said to a family, I would say it's very unlikely he will survive, etc., what would that mean to you? And what we found is that the average chance of survival that the clinician was intending to convey was 9%. So this gives us a way to compare qualitative and quantitative prognostic statements. And this is the outcome measure we used. I think it's important to look carefully at the question. We didn't ask the surrogates, what do you think are the chances the patient will survive? We asked them, what do you think the doctor thinks are the chances that the patient will survive? Because if we're trying to get at misunderstandings, we're trying to exclude from the analysis the things that surrogates do with information once they understand and receive it. So how they appreciate it, what other things come into their interpretation of it. So by asking, what do you think the doctor thinks, we were really trying to get at their narrow understanding. And then we asked them to place a mark on a probability scale. So what we found is that there was no difference between the two groups in terms of the proportion of, in terms of the understanding in the quantitative group, 10% chance of survival, and the qualitative group, the mean 17 and 16%. So numbers not clearly better than words. And if you just take a step back and look at the means here, you say, well, this is pretty good. Surrogates can understand this information. They got close, and that's probably close enough given the uncertainty. But the other way to look at this is to look at the standard deviations, right, which are very big, plus or minus 22% and plus or minus 27%. So when you look at the distribution of perceptions on the part of surrogates, they were quite broad. So only 52% of the subjects in the quantitative group, in the group that heard 10% chance of survival, actually estimated the patient's prognosis to be exactly 10% chance of survival. And 1 in 5 subjects estimated a greater than 40% chance of survival. So again, I think the answer is a little more complicated than either they do or don't misunderstand. There, in a certain proportion of cases, misunderstanding does appear to be a problem, even when the information is disclosed in a very clear, very simple way. But about the same time, we were doing a separate study in which we were eliciting prognostic estimates from clinicians and surrogates, and this is what's called a scatter plot. So basically on the x-axis we have the physician's estimates of survival, and on the y-axis we have the families. And for the investigators in the room, this is why I think it's so important to actually look at your pilot data. If it was true misunderstanding that was the issue, that the surrogates just didn't get it, or the doctors never talked about it, and so people were all over the map, you'd expect a random distribution of the scatter plot. Perfect agreement would be right along this line, right? The doctor says 20% chance of survival, the family says 20%. And a random distribution would suggest it's truly just random. There's no method to this. But instead what we saw is that there was a skew of the data to this quadrant. And this quadrant is the optimism quadrant, right? If you haven't figured that out already. When the physician said 20% chance of survival, the family said 50 or 60 or 100. And it was quite a predictable skew that we observed. So we looked at this and also consulted the psychological literature of risk perception, and people are laughing. I guess this is an NPR crowd. People know Lake Wobegon and news from Lake Wobegon, right? So the optimism bias is what we speculated may be going on here, which is a cognitive bias that leads people to overestimate in relation to others their likelihood of experiencing positive outcomes and avoiding negative outcomes. And it's actually called the Lake Wobegon effect because of the sort of opening line to Garrison Keillor's monologue is often, or I think is always, where all the women are strong, all the men are good looking, and all the children are above average. So what I didn't tell you is that we also set out to test this hypothesis. We had a third hypothesis, and we hypothesized that there will be discrepancies between surrogates' understanding of physicians' prognostications and their actual belief, their own individual belief about the patient's prognosis in the direction of optimism. So to get at this, we need to sort of go back to some methods here. Remember that first question we asked the family, what do you think the doctor thinks are the chances the patient will survive? And they gave us a response to that. But we also asked them, what do you think are the chances that the patient will survive? And the distinction between those two is not misunderstanding, right? That quantifies a difference in belief between the physician's estimate, as the surrogate heard it, and what the surrogate actually believes.
They wrote them on the same scale?
They wrote them on separate scales. So we tried to avoid an anchoring effect. And for lack of a better term, we characterize this as difference in beliefs. And so what we found is, in fact, when you look that there is a difference in belief. When you look at the surrogate's best estimate of the physician's prognostications, and this is aggregating both groups because there was no difference between the quantitative and the qualitative interpretation. The mean was 16%. When you asked the surrogates their personal belief about the simulated patient's prognosis, the mean was 23%. So even in an incredibly artificial situation, watching a video about a patient that they've been told repeatedly this has nothing to do with your loved one, this is a simulated experiment thinking about doctor-patient communication, optimism bias is sort of pressing its way in. We were sufficiently surprised by this that we, in sequence, actually later in the study, we took on a different approach to studying the same question. And I want to give a lot of credit to Lucas Zier, who was an MPH student at Berkeley at the time and then subsequently stuck with us during his whole internal medicine residency at UCSF. But we enrolled 80 surrogate decision makers from the UCSF ICUs, and we asked them, we gave them on individual sheets of paper 16 different prognostic statements and asked them, if the doctor said this to you, what do you think that would mean? And if the surrogates' estimates differed from what would be the expected statement based on the prognosis, we asked them to participate in a semi-structured interview about why. So let me just show you what I mean by that. These are the 16 different prognostic statements that we gave them, and they were given in a random order, but I've organized them here hierarchically according to the severity of the prognosis. On the top, he will definitely survive, all the way down to he will definitely not survive, and with worsening of the prognosis as you go down. What I want you to pay attention to are the three numeric prognostic statements. He has a 90% chance of surviving, he has a 50% chance of surviving, he has a 5% chance of surviving. And so what we did is we gave these to the surrogates, as I said, in random order and asked them to place a mark on the line in terms of if the doctor said X to you, what does that mean to you about the patient's chance of surviving? And again, went to great length to disabuse them of the notion that this has anything to do with their loved one. So what we found, these are the data. Does anything jump out to people? Let me tell you what each of these bars are. So the green is the interquartile range. So this is the range of responses, 25th to 75th percentile. The diamond is the median, and the X is the mean. So basically this shows a couple things. The first is that surrogates can, in fact, understand a discrete numeric prognostic statement, right? The median interpretation of 90% chance of survival was 90% chance of survival. This is some evidence that numeric statements can adequately convey risk information. But where it got interesting is that when you look at the other numeric prognostic statements, the answers they gave were not the same as the intended response. So for example, look at the confidence intervals, or look at the interquartile range around 50% chance of survival and then down to 5% chance of survival. The median response for 5% chance of survival was 23% chance, and that's the mean, and the median was 15% chance of survival. So again, this is not misunderstanding. This is something else. And for these individuals who displayed this trend toward increasing optimism in their interpretation of the prognosis worsened, we asked them to participate in a semi-structured interview. And I won't go into all the data, but what we found was two things. First, about half of the subjects who had this trend had no idea that they were doing it. We lined up their three statements in front of them and said, take a look at these estimates, and can you tell us why you put the marks on the page where you did? And as I said, what was amazing is that about half of them looked at it and said, they looked at their 5% estimate where they put 20%, and they said, I had no idea I was doing that. So it was a subconscious process. And then for those who were able to offer reasons, the kind of reasons that came up were in fact supportive of the optimism bias hypothesis. So, one of the strongest reasons was this notion of performative optimism. I always hope for the best for my husband. even with a 5% chance of survival, there's hope. I guess I understand that the patient may eventually die. I just have to hope more. The second general type of answer was surrogates believing that doctors generally don't understand patients' internal fortitude, right? So they were making a distinction between what clinicians typically believe about their cohort of patients and what they know about their individual loved one. And lo and behold, it tends to be a more optimistic view that people hold about their loved one relative to the population. This is in fact the definition of the optimism bias, right? Where all the men are good looking and the children are above average. That's the definition of the optimism bias. So there are obviously some limitations to these studies, right? These are hypothetical cases, and it may be that the true nature of the doctor-patient relationship overcomes whatever we were detecting in these hypothetical simulations. So as part of an R01, we sought to determine whether this actually comes up in actual clinical practice. This was part of a multi-center mixed method study examining how clinicians disclose estimates of prognosis among 469 surrogates, again in which we audio recorded conversations. But we assessed both the clinicians' estimates of prognosis and the families at the same time point on day 5 of the ICU stay, using a very similar scale. We asked, what do you think are the chances the patient will survive this hospitalization, to both the clinicians. First, we got the physician's prognostic estimate, then we got the surrogate's prognostic estimate using the same question, and then we asked the surrogate, what do you think the doctor thinks are the chances the patient will survive? And so what this left us with is something that could look like this, where if the physician, for example, said, I think there's a 25% chance of survival, the family guessed that the physician thought there was a 75% chance of survival, that we characterized as misunderstanding. They just didn't understand what the doctor was saying. And then the difference between what the surrogate thought the doctor said and the surrogate's own prognostic estimate, we characterized as a difference in belief. And so to answer that question of is difference in belief an issue in actual practice, we characterized the proportion of cases in which each contributed. So what we found is that in half of cases, there was discordance of any type between the clinician and surrogate of at least 20% regarding the patient's prognosis. In 22% of cases, it arose from both misunderstanding the clinician's intended prognosis and disbelieving it. In 26%, it was purely misunderstanding as measured, and then in 4%, it was disbelief alone. The surrogate said, the doctor told me 10%, but I think it's something else. What this suggests is that it's not simply an issue of misunderstanding. And let me just summarize the main findings here. The frequent disconnect about prognosis likely has multiple causes, some of which may be at play in some cases and not at play in others. Incomplete disclosure by clinicians, misunderstandings in the strict sense of misunderstanding by surrogates, and optimism bias and other psychological processes causing disbelief. So just taking a step back from the research side of this for a second, what are the clinical implications of this? Well, when I teach on rounds about this, I talk a lot about mental models. How do we conceptualize what's the issue when we're confronting a hard case in an ICU? And I think a common mental model, which is one I don't recommend, but is often comes up in the ICU, is the clinicians just frustrated saying the family does not understand what's going on. They don't get it. And the response, if you're a logical, rational person, is to say the same information again, maybe in a slightly different way. I think that mental model is not consistent with the data, and a better mental model that I would propose for clinicians when confronted with situations in which the gist of what they're getting is the sense that the family doesn't get it, is to rather than make a claim, to ask the question, what's keeping us from being on the same page here? And there are several things that could be going on. These are the sort of 4 questions that I ask myself. Have I not really addressed the prognosis as clearly as I should? Have they misunderstood it? So do I really think, are they saying things that make me think that they really didn't hear what I said? Is the family emotionally overwhelmed and in denial? Or do they simply have a very different belief system, or what in the sort of social sciences we call explanatory model of illness? Do they think that what determines outcomes is something other than the traditional biomedical model of physiology determining outcomes? And this doesn't give you an answer on how to intervene, right? We still sort of defer to clinical judgment on, okay, what should I do here if I think this is the issue, or here, or here. but I think it at least prevents us from taking the wrong tool to the conversation, from when we should be focusing in on emotionally supporting families instead of us hitting them over the head with the same prognostic information, but just louder and more often. All right, so let me switch gears a little to talk about an in-progress work developing an intervention to improve surrogate decision-making in ICUs that largely arises from these data. So another aim of this R01 that I told you about was not only to understand what's happening, but to understand key stakeholders' perspectives on how clinicians can more effectively disclose information about prognosis. So at 3 U.S. academic medical centers, we did in-depth interviews with 114 different participants, surrogates, both during the ICU stay and 6 months later, ICU clinicians who'd been engaged in conversations, and then national experts in decision sciences and palliative care. And the question was, just as I said here, what are your perspectives about how to more effectively convey prognostic information to surrogates in ICUs? And what was really interesting about the responses were that it's not, if you're going to design an intervention, you should design an intervention that's not just about disclosing risk, that's about supporting surrogates in a much broader way. So that the discussion about prognosis is a subcomponent of a more expansive intervention. And the kinds of things that experts, surrogates, and clinicians, there was a great deal of uniformity in their responses, raised were focusing on building relationships and trust early, discussing early the possibility of death, so surrogates have time to begin to grapple with that information, focusing on the gist of the prognosis rather than overly precise prognostic estimates, which I think is also a good insight into how patients tend to use this information. Having an intervention that facilitates true engagement of surrogates in eliciting values and talking about prognosis and decisions and options. And then, most importantly, providing intensive emotional support to surrogates. So we took this information as well as a systematic review of what the existing evidence is regarding surrogates' needs in ICUs and summarized it into 3 different categories, 4 if you've split it, of things that should be addressed in interventions to improve surrogate decision-making. The problems to address are the overwhelm that families experience, the breakdowns in the actual getting the clinician and family to the table to have conversations in a systematic way, and then once at the table, that sometimes there are important omissions in discussions, as we've talked about, of prognosis, patient values, and treatment options. So we spent several years developing and pilot testing what we've called the 4 Supports intervention, which is a nurse-led intervention to improve surrogate decision-making for patients with critical illness. And essentially, the gist of it is, if people are familiar with the patient navigator type of intervention that exists in some hospital domains, this is essentially adding a specifically trained navigator or interventionist or concierge to the ICU team to establish a relationship with the family from ICU day 1 that's largely an emotional and supportive relationship, and then to provide 4 different types of support: emotional support, communication support, decision support, and anticipatory grief support. And what do I mean by each of these? Well, so this is the gist of the intervention. On the left are the 4 different kinds of support. So essentially the interventionist, who goes through a fairly intensive training process, as I said, establishes a longitudinal relationship with the family and identifies themselves as, number 1, a member of the ICU team, and number 2, their main contact on the ICU team. So this checks in with the family every day and assesses not only what are your needs and concerns, but how are you doing and what can we do to help you in this critical time. Communication support, I'll say a little more about how we do this, but the interventionist takes the lead on scheduling and making sure the family meetings are happening. Decision support, this is the sort of the chunkiest and most intensive part of the intervention. The interventionist engages the surrogates in what are called values clarification exercises, helping them think through what are the patient's values, what's known about their preferences, and what are their general health-related values. And then in the family meetings, nudges clinicians to address key topics: prognosis, the patient's values, and what are the reasonable available treatment options. And then finally, for the cohort of patients who are not expected to survive, The intervention involves essentially what's called anticipatory grief work for the surrogates, which is a series of steps to allow the surrogates to, in advance of the patient's death and during the patient's death, to have a more structured time to begin to reach closure and to say what they feel they need to say to the patient, even if the patient cannot hear or respond. So let me just point out two relatively novel parts of the intervention. First, the intervention leverages principles of behavioral economics that involve the power of defaults. So this essentially what this intervention does is flip the default about how family meetings occur from an on-demand schedule that the clinicians decide it's time to have a family meeting, and we know from existing data that that tends to make family meetings happen later and less frequently than may be needed, to flipping it that the For Supports interventionist schedules the meetings, gets the family ready for those meetings, and gets the doctors to those meetings and other clinicians, including the patient's outpatient provider, according to a preset schedule that the ICU teams in advance of this trial agreed to be part of. And essentially what the schedule is having family meetings within 48 hours of ICU admission and then at least every 5 days thereafter. 5 days is a floor below which things can't go. But obviously, if things are happening more quickly and more aggressively, family meetings can happen every day. And we've had cases where the patient is imminently dying, and the family meetings happen sort of 3 times over the course of 6 hours as decisions are being made. The second, this is just explaining the background of the defaults. And these are for people interested in the psychology of decisions and how people make decisions and how to influence them. These are 2 great books I recommend reading, Predictably Irrational by Dan Ariely and Nudge by Thaler and Sunstein. The second behavioral economic principle that we've engaged in this intervention is what's called a focusing effect. And I'll say a little more about what that is in a second, but what happens is that before each family conference, the For Supports interventionist elicits from the family their current expectations about the patient's prognosis on these 2 scales, and takes these 2 scales and shows them to the clinicians who will be running the family meeting, and says, so the family thinks there's about essentially an 85% chance of survival and about an 85% chance that the patient will be free of severe functional impairment. Does that accord roughly with what you think the prognosis is? And if the clinicians quite often look at it and say, no, that's not at all what I think is going on, then the interventionist prompts or nudges them to say, this may be something that we should bring up in the meeting. Is it okay if it hasn't come up that I raise this? And so this leverages both prompting, which has been shown to change clinician behavior, as well as a focusing effect. And this is Danny Kahneman, who wrote Thinking Fast and Slow. He's a Nobel laureate with Amos Tversky. A focusing effect is the psychological tendency to place more importance on a factor that a person is prompted to consider. And so I think it's especially apropos to cite this article. Do people know this article by Schade and Kahneman? So this was a famous decision psychology experiment where they polled students in Michigan and I think at UCLA about their life satisfaction using validated measures. And lo and behold, the answers were just the same. Life satisfaction was the same between Michigan and UCLA. But they asked these students to rate the perceived life satisfaction that students at UCLA might have. And lo and behold, in California might have. And lo and behold, both the UCLA students and the Michigan students assumed or reported that they perceived the life satisfaction would be higher in the students at UCLA. And the only difference in the way they structured it was talking about the weather. There was a fair amount of time devoted to the weather. So it's a focusing effect, right? We think that the weather, and having just come through a Pittsburg winter, I'm feeling like the weather does matter. But in terms that, it doesn't bear out empirically. The satisfaction is the same, the life satisfaction between these 2 groups. But when they were nudged or prompted to focus on this in an implicit way, it affected their responses. And there have been a number of studies that show that focusing effects can change how people deliberate. We're using that to focus, to reframe decision-making in ways that we think are consistent with existing ethical paradigms of informed choice. You can obviously use these things, and advertisers do use these things to manipulate decisions in ways that are maybe not so ethical, but we think that there's a very strong justification to nudge in this direction. And so this has culminated now in a trial that's ongoing, funded by the NIA. Unfortunately, the data are not out. We're still enrolling. We've actually only been enrolling for about 4 months, but it's a randomized trial in 4 ICUs within the UPMC Health Network. We're enrolling 400 surrogates of ICU patients who are at high risk of death, at least a 60% chance of in-hospital mortality by Apache scores. And we're randomizing them to receive either the forced sports intervention that I've described, or a brief educational intervention that is largely an attention control. They're having the surrogates are undergoing both 3 and 6 month follow-up, and the key outcome measures that we're assessing are surrogates' 6-month symptoms of depression and anxiety, with a host of secondary outcome measures: patient's 6-month survival and functional status, health system costs, so both the hospital costs as well as the 6-month healthcare costs, and then various elements of decision quality. So essentially asking the question, does this intervention lead to more informed decisions and more patient-centered care? So perceptions of prognosis, a validated scale of patient-centeredness, and then a validated metric of decisional conflict. And I wish that I were giving this talk 2 years from now when we'll have the results, but this is where we are now with the process, and it's an interesting question about, can we move from an empirical observation about prognosis through key stakeholder engagement to a trial that doesn't exist in this sort of traditional realm of an informed consent intervention and takes a more psychodynamic and psychological approach. So stay tuned, and I think I'll stop here if that's okay and leave a little bit of room for questions. Thank you very much.
Questions for Dr. White?
Why is it important that the surrogate have the same opinion of prognosis as the decision maker? Why not let them be in a little bit more state of optimism?
Yeah.
What's wrong with that?
Yeah, it's a great question. Why do we care about whether surrogates have an accurate understanding of the prognosis? Well, I think there are two answers. The first is this, that if surrogates are, before you even look at this, we also looked at who's more accurate when in these data from the R01, the NHLBI R01, and found that clinicians are substantially more accurate in predicting hospital survival than families. That's the first thing, is that we hope that these decisions are informed by an accurate understanding of the patient's actual circumstance. What we found is that when surrogates are overly optimistic, it leads to substantially more healthcare utilization. Right? So longer hospital length of stay, longer ICU length of stay, longer duration of mechanical ventilation, and no difference in survival. So on the one hand, the decisions appear to not reflect basic requirements of informed consent, and on the other hand, there appear to be patient-related harms that are arising from these decisions. Those are the two main concerns, I'd say.
And also conflict between the physician and the family's patient at a time of stress cannot probably increase their quality of life, and sometimes you need to pull in a futility part at that point, and it just, when you're not on the same page, everything just goes worse for everyone emotionally too, I think.
Right, indeed. Right. We haven't talked much today about moral distress, which is another thing I think is an extremely important topic in intensive care units. These are the cases that engender moral distress, when the clinicians feel that what they're doing to patients may either not be consistent with patients' values or not likely to work.
Did any of the 80 surrogates have previous medical training or ICU experience? And
Right.
Why do you think the outliers, the ones that were below the line in the testing society, why do you think they were there?
Yeah. I do not recall whether any of them had medical experience, so I'm sorry, I can't tell you that. And for why there were some who were pessimistic, it's a great question, right? And it actually reflects even more complexity in the data than I presented today. The way I presented it, it made it sound like all the discordance was around optimism. But in about 5% of cases, surrogates were pessimistically discordant. They were much more pessimistic than even what the clinicians thought the prognosis was. And we interviewed those surrogates too and found that in this is sort of a different phenotype. These are surrogates who said, for example, mom's had enough. She doesn't have the same will to live as for essentially the average ICU patient. And that just as the doctor didn't know the things that made the more optimistic surrogates feel that the patient was going to outdo the sort of mean, these are surrogates who were saying the doctor doesn't know that mom's been through this for the last year and she's done. She told me months ago she's ready to stop. She doesn't want this.
I want to go back to that previous question and about these outcomes. When there's not a concordance with the prognosis, what do we know about the bereavement outcomes?
Yeah.
And does it have an effect on it?
Great question. We don't have those data. We will have that. One of the things that we're studying in the Four Supports trial is complicated grief, Ferguson's inventory of complicated grief, and as well as depression and PTSD symptoms. What we know from the literature on complicated grief is that one of the main predictors of complicated grief is that the death is unanticipated. In the conventional sense, someone killed in a motor vehicle accident. But some of that conceivably and could translate into the ICU, where even if a patient's in an ICU, surrogates are, my clinical experience, and I imagine yours, is sometimes they do not equate being in an ICU with being at high risk of dying. And when a patient does die, it can be quite surprising to families sometimes, i.e. an unexpected death. So to the extent that those two things are linked, I think there may be a relationship between undue optimism and adverse outcomes in surrogates.
Yeah, a couple comments and a pragmatic question. So my experience has been that patients' loved ones are always different from everyone else, and they always will survive when no one else can. So that to me, your second comment seems to be extremely common in my experience. I can't remember my second comment. I guess we can move on to the question, which is that, I guess my second comment is that the more I do this, the less confident I am about the patient's outcome, if you want to know the truth.
Mm-hmm.
Because I've seen patients I'm convinced are going to die that don't, and vice versa. My third question.
Can I respond to that
Sure.
in a second? So if this is why giving probabilistic estimates is a much more, you're going to end up much more accurate because Steve, you probably are more accurate than you know if you're saying, well, listen, in a cohort of patients as sick as this one, I bet about 80% survive. You may not know whether that patient's going to be one of the 20 or one of the 80. Right. But if you were asked, yes, no, is this patient going to live, die, that's a much harder thing to do.
So that's actually the approach I use now. And so that brings me to the third thing, which is in the spirit of discussion, I oftentimes leave room at the end for the patients' families to bring up concerns and questions. Mm-hmm. And invariably, one of the things that comes up is, well, can you say 100% for certain that my father is going to die? And
right.
Of course, I'm stuck because, no, I can't say 100% for certain. That little bit is the hope that everyone's looking for. And how do you squirrel out of that? Because you can't say that I'm 100% convinced. But everyone then gloms onto that.
Okay, so right. So let me respond in two different ways. So I'll give you two different statements that you could respond to that by. And you tell me if they feel different. I think they feel very different. On the one hand, you could say, yeah, you're right. I can't ever tell with 100% certainty what's going to happen to a patient, period. That's the expression. That I suspect that does a number on surrogates' willingness to act on the information because it feels unbelievably uncertain. On the other hand, you could say something like, well, of course, I don't have a crystal ball that's 100% ever accurate. That's just that doesn't happen in the world. What I can tell you is that based on X data and my clinical experience and my consultation with colleagues, is that we think it is there's almost no chance your loved one's going to survive. That will not dissuade surrogates, the small cohort who say you have to do everything for every person, until there's no chance of surviving. Those are cases that may well lead to intractable conflict. But I would argue that second framing will help sort of pull people to a more realistic appraisal of the uncertainty that we swim in every day. And again, getting back to the data that I showed you about surrogates' willingness to tolerate uncertainty, my experience has been that, yes, there are these cases where people want absolute certainty, but they're more rare than common. And quite often it's more clinicians are uncomfortable talking about uncertainty and talking about prognosis in the face of uncertainty.
So I have a question for you. I'm a nurse at the bedside observing clinicians with their prognosis to the surrogates. And my concern is, I love your study. How do you look at this from just one physician, one clinician giving that information?
Right.
Because in multi-system failure in the ICU setting, we don't have one clinician. We sometimes have four, and they all have different opinions on how they approach the patient about the prognosis and the diagnosis. So when you talk about the surrogate absorbing information, often it's very different information from 3 or 4 different clinicians. It seems to be a problem.
Right. So I agree. And I think that this is not just if it makes you feel better or worse, you're in it with most ICUs around the country that have some consultative or open element to it. This is the reality, that when multiple subspecialists and specialists are talking to families, even if the messages are relatively similar, may hear different things. So first of all, I think it's an important issue for health systems to confront and say, how are we going to respond to this potential pitfall? Second, the force supports intervention is part of the intervention, is the interventionist helping families make meaning. Number one, helping families make meaning when they get disparate estimates or disparate information. And number two, minimizing the frequency with which that happens by trying to do behind-the-scenes work with each of the clinicians involved to say, here's how we're approaching things. Does this match with your expectations? If it doesn't, let's make sure we talk about it as a team before you go in there and talk to the family. So that's again, a part of the intervention. Will it help? We'll see.
I was wondering about the interventionists, like the way you describe their role. I was wondering kind of how you contrast to the role that palliative care often.
Right.
A lot of those things, like the clarification of goals, emotional support, is kind of what they often do as well. And I know they're not necessarily associated with community ICU, but other than that, they often are like long-term partners. And then related to that was that values clarification. In that slide where you had how can we be on the same page? Like I feel like the first 3 things are things we can do something about. Did I provide enough prognostic information? Can I emotionally support the family? The last one is their values are just their whole belief. I was wondering, what advice do you have when you're dealing with that situation? If it comes down to that, you can't really do anything about that. What happens?
That's not a low-hanging fruit. But let me take your first question first. I think you should talk to Neil about your second question and Tom, because that's their wheelhouse, which I tend to agree with. Actually, let me take your second question first and get it out of the way. I think those cases arise of intractable value conflict between families and clinicians. I think those are incredibly hard cases. I think they're much rarer than we think they are. I think what looks a lot like intractable value conflict often arises when communication has broken down between clinicians and surrogates. So my answer is yes, a few of those cases will arise, maybe more at the Westwood campus, as I'm hearing about some of the interesting things here. No, I don't mean to say that in any disparaging way, but to say that there were certain times that deep value conflicts will come up. But I think quite often they can be that things that look like deep value conflicts are not. And intensive early engagement can prevent relatively solvable conflicts from becoming intractable. That's the first point. Second point regarding palliative care can't get involved on day one. Right? Nor, if you look at existing workforce estimates, can palliative care scale up to the kind of frequency that we're talking about. This is probably 12 20% of ICU patients, patients that would be eligible for this kind of intervention. And we know from Hannah Wunsch's work and others' work that there's just not the palliative care workforce that can scale up to do this. But yes, it's an absolutely similar role, and I would frame it as incorporating principles of palliative care into the practice of intensive care medicine routinely.
Oh, your first point, I just moved here from Michigan, actually, where the weather is terrible. But I was happy there. But in Michigan, we have a lot of, like, in practice, the values thing comes up a lot. There's the biggest Muslim population outside of the Middle East is in Dearborn, Michigan.
Huh.
And also religious, like there's a lot of religious people in general, like Christian and all of that, and they will not let you turn off any intervention.
Mm-hmm.
Agreeing to that is tantamount to,
killing.
Yeah, exactly. Yeah. So that does actually came up a lot for us, like values.
Undoubtedly. And then I think this is where it's really important to have a good hospital policy where the clinical ethics consultation service and the hospital leadership are willing to back up clinicians when they get to a point where they say, what the family is asking me to do, in my best judgment, is outside of good medical practice, and I can't, in good conscience, provide it.
Waiting for a miracle. It's always like a miracle that's going to happen to baby.
So we're going to wrap this up. For those who want to continue this conversation and have further discussion, Dr. White will spend another hour with us in the 200 building in room 447 for an open question and answer period. I want to very much relish the fact that pulmonary and ethics get together like this.
Yeah.
And I want to thank pulmonary for arranging this to happen and for Dr. White coming out. Thank you very much.
Thank you.
In about 2 years, when you have all your stuff together, you want to do one of these just there or not.
Shannon and I have another conversation. Shannon Carson's one of the others that they.
Well, now, I try to stay through. Actually, this is actually personal stuff. And there's not very much science now there is. So I'm kind of like to do stuff like 4 or 5 years. So we're gonna figure out between this and August, it's all fine by obviously 2016 or 17. Should I enroll one of my guys and one of you and whoever you want? I mean, be good, I think, yeah. It's actually fun. This has been a good journal. These are good. Where we're at. I was.
It used to be hardcover, yes?
No, Clinicians and Surrogates medicine is hardcover. This has always been hardcover. But most are recent.
you.